Tick-borne diseases and cardiomyopathy. Presentation of 3 cases with discussion. Kenneth B. Liegner, M.D. Lids Conference. Newton, Massachusetts. October 28, 2007. Background. Substantial literature exists for carditis from Lyme disease, including cardiomyopathy. Fatal case of pancarditis with Lyme and babesiosis co-infection reported by Marcus et al. 1985. Bartonella, rickettsia, pyroplasms and mycoplasms also have been reported to cause carditis. Besides Babesia microti, WA1, and MO1, wide range of pyroplasms/thiolari exist in wildlife and ticks in nature. Test methods to detect the full diversity of pyroplasms found within ticks are not clinically available. The extent of human disease caused by diverse pyroplasms almost certainly remains incompletely defined at present. Case 1, Slide 1, first seen by me, 705. 58 years. Mean Army National Guard, previously healthy. 801 on training maneuvers in coastal New Brunswick, Canada, camping in field with high grasses x2.5 weeks. Deer in vicinity. Tents had no floor canvas. Noted circular bruise-like area left shin, orange to grapefruit sized, no known history of trauma, no known tick attachments while on maneuvers. 6+ weeks later, flu-like symptoms, back pain, chills, night sweats, joint pain, limping, numbness in legs, later fatigue, cognitive problems, decreased stamina and endurance. Case 1, Slide 2. Summer row 2, felt unwell. EKG, complete heart block, pacemaker placed. Lyme suspected but tests negative. Dyspnea developed with impairment on PFDs. Coronary angiography, virtually normal coronary arteries and normal no CHF. Chest CT, prominent mediastinal lane, sarcoid considered, paratracheal and cervical lane BX, non-necrotizing granulomas. Consistent with sarcoid but not felt definitely diagnostic. A physician felt Lyme plausible, 30 kDa band on Lyme Western blot. Tetracycline applied 204 to 704 with benefit, Biaxine and Plaquenil 704 to 605, heart block did not resolve and patient remained pacemaker dependent. Paratracheal and mediastinal lymphadenopathy improved following antibiotic treatment. PFDs improved with ABX. 405 ventricular tachycardia on EPS-pacemaker removed and defibrillator/pacemaker inserted. Despite maximum doses of sotalol, recurrent VT with repeated automatic defibrillator discharges. Case 1, Slide 3, 705 minocycline begun. VT episodes appeared to have subsided and VT was not inducible with defibrillator testing/programming 2 weeks after minocycline begun. Initial labs obtained at my evaluation 705. ESR 45 mm/h Ig lambda and immunofixation Coxsackie B1 B6 negative Lyme Western blots, Stony Brook, Elisa, IgM 41, 30, Ig 30 MDL, IgM 41 Ig no Banzignex, IgM ++28 +31 +39 ++41 +58 +66 IND at 18, 30, 34, 45, 93 Ig +30 ++41 ++66 IND at 28, 31, 39, 45, 66. Case 1, Slide 4, Initial labs and diagnostics, continued. BM Ig ETHA 120 Ignex, negative at Quest. BM Fission Egg. Brain SPECT, severe global cortical hypoperfusion with heterogeneity, white matter involvement noted. Angiotensin converting enzyme 141, ULN 67. Thick and thin GM smears for Babesia/pyroplasms negative. Case 1, Slide 5, subsequent testing. 506 Stony Brook Elisa neg WBIGM, 72, Ig, 29,93. 506 IGN XIGM plus 28 plus 41 plus 45 plus 66 IND at 31,39 Ig plus 28 plus 41 plus 58 IND at 31,39. 506 IGN XBM IFA plus 1:20, BM Fission Egg. 806 Stony Brook Elisa neg WB, IGM 41 Ig 41,93. 806 IGNX, IGM plus 41, plus 58 IND at 23,31,34,39 Ig plus 30 plus 41 plus 58 IND at 31,39. 806 PM IFAs at Quest and IGNX neg. Case 1 Slide 6 Treatment Interventions and Outcome. Minocycline 705 present. Platinum-added 106 to 506, arguably therapeutic both for Lyme and sarcoid. Prednisone by pulmonologist for possibility of sarcoid late winter/early spring 06. 406 repeat echocardiogram, decreased F to 30 to 35% with moderately severe global hypokinesis, worsening occurred after prednisone added. LV had never been impaired until prednisone utilized. Discussion held with patient by his pulmonologist regarding consideration of cardiac transplantation as a possibly necessary contingency. Empiric addition of Molar-1 for possibility of babesiosis/piroplasmosis 506 to 1106. 806 repeat echo 60%. Repeat echo 1106 still satisfactory at 60%. One episode of VT1/07 felt related to hypokalemia. Patient has strong sense that Mino and Molar-1 was responsible for dramatic turnaround in status and feels that prednisone did not improve his condition, and resulted in impaired LV. Complication of antimicrobial Rx, gray-blue skin pigmentation lower extremities secondary to minocycline. CHB never reversed despite antimicrobial Texas, unusual for Lyme disease alone. Global status substantially recovered and satisfactory quality of life. Case 1 Slide 7 Considerations and Discussion. Did this patient have Lyme disease? Did this patient have babesiosis/piroplasmosis? Did he have sarcoidosis? Did he have 2 or 3 of these conditions? Did Lyme disease trigger sarcoid or a sarcoid-like illness? Did he require antiboreal and antipiroplasm/antibabesia treatment? Did he require prednisone application? Was combined prednisone and antimicrobial therapy necessary and beneficial in his case? Would he have recovered without some or all of the applied treatments? Case 2 Slide 1. First seen 1205 54 years. WM. Extensive epidemiologic risk for tick exposures in MA, Pacific and W, Virginia, Minnesota, Maine. At least 12 known tick attachments, no known IM rashes. 1103 CHF develops. Non-smoker. Previously physically fit and active. Normal coronary arteries on angiography, but dilated cardiomyopathy. Developed syncope secondary to VT which was recurrent which coincided with onset of CHF. Pacer/defibrillator placed. Recurrent bouts of paroxysmal AF as well which have triggered defibrillator. Medical/cardiologic treatment, Coreg, Carvedilol, Aldactone, Diavan-Valsartan, Digoxin, Coumadin, furosemide PRN. Sarcoid R/OD. Plus history of Ehlers-Danlos syndrome. 705 A prior physician found suspicious bands on Lyme WB and plus antibodies against WAL babesiosis. Rx by prior physician included Ctec, Dorix, Omnicev, Flagyl. On Ctec and Mipron developed AF and was cardioverted. 1005 Increasing dyspnea and decreasing exercise tolerance. fevers and night sweats. Idgenex Lyme WB6 bands. For Rosafenex 28 days November/December 2005 with some benefit. Increased exercise tolerance. Case 2 Slide 2. 1103F when CHF first diagnosed, 20%, LV diameter 7.3 cm. 206F following antibiotic and anti-Babsia Rx increased to 35% and LV diameter 6.3 cm, decreased by 13.6%, global hypokinesis, LV moderately dilated, RV mildly dilated and decreased systolic function. Case 2 Slide 3 Pertinent labs/diagnostics. 1103 Coxsackie AB B1B6 neg. 1005 Idgenex Lyme WB, IG++ 18 + 28 + 31 + 34 + 41 + 58 IgM + 31 IND 23. 1005 Quest WA11 to 128, NL less than 164, BME for negative. 705 MDL Lyme WB IG 31 Lyme C6 neg Lyme Elisa neg. 705 Stony Brook Elisa neg WB IG 30 CADA. 805 Bartonella Hensley EFA neg. Heavy metals neg. 1205 IgM 308, ULN 271. 1205 Stony Brook, Elisa neg WB IG 30 CADA. 1205 MDL, Mycoplasma fermentans PCR plus at 24,900 copies/ml. Sonoma Company. Do WA1 EFA plus at 1 to 640. Case 2 Slide 4 Treatment and course. 1205 After sequencing off 28 days course of 4 CFTRX, oral minocycline begun. Malaria-1 added after 1 month for combined Rx versus Lyme and WA babesiosis. Remained on Mino and Malaria-1 1205 at least through 1006 when patient was lost to follow-up. Progressively improving sense of well-being and exercise capacity. Dysrhythmias become a non-issue since 1005. Atrial ventricular dyssynchrony resolves. Patient avers addition of Malaria-1 conferred most dramatic symptomatic improvement, sweats resolved with Malaria-1. Able to walk 4 miles at 4 miles per hour and play basketball x 40 minutes, able to bike 10 miles. Repeat Mycoplasma fermentans PCR at MDL negative. Last labs 906, Quest WA L1 to 256, NL less than 164. Quest BME for neg. Stony Brook Lyme Elisa neg WBIGM neg IG 30, 41, 34. MDL Lyme WB IG 31, 41 IgM no bands. Idgenex, IgM IND at 23, 31, 39, 41. IG positive + 18 + 28 + 31 + 41 + 58 IND at 23, 34, 39. Negative by CDC criteria. Case 3 Slide 1. 49 years. WM, resident of a southwestern U.S. state. Previously healthy, physically active, hiker, camper, runner in mountainous and wooded regions of the West and the Pacific Northwest. 1 probable and gorge tick attachment 1984 without obvious illness. No history of ECM. 1204 Heart irregularity noted on insurance physical, advised to follow up with personal physician but did not do so. Retrospective review showed AF. Spring 06 noted heart flutter while backpacking. Cardiologist found atrial fibrillation and echo with markedly reduced F at 25%, NL 55%, with dilated LV. Coumadin started. Fall 06 cardiac cath, normal coronary arteries. LV enlarged, F 20%. Coxsackie viral titers neg. Echoviral titers neg. EBV AGAB+, CMV AB+, RMSF ad neg, PCR SBB, VH, neg. 1106 Lyme WB at MDL, Ig 39,41, faint 28, 60, IgM faint 41. 1106 Lyme WB at Stony Brook, IgM 41, 18,62, Ig 37. 1106 Lyme WB at Agenex, IgM plus 41 Ig plus 41 plus 58 faint 23,31,39. 1106 SWA Lab neg, BM fish neg. 1106 AB and PCRs neg BH, AB HME/HGE neg. Case 3 Slide 2107 Lyme Elisa Stony Brook positive. Stony Brook WB, IgM 41, 18,64. Ig 37. 107 WB at MDL, Ig 39,41 and faint 23,28,30,60 IgM. Faint 41. 107 WB at Agenex, IgM plus 30 plus 41 plus 58. IND 34,39. Ig plus 30 plus 41 plus 58. IND 39. NA plus 180 homogeneous. ACE normal. C3/C4 and C1q immune complexes normal. Hantavirus ab neg. 107 BM EFAs, fish, PCR at Agenex neg. Case 3 Slide 3. Despite severely compromised cardiac function, patient has minimal symptoms and does not endorse shortness of breath on exertion. Does not endorse multi-system symptoms as often seen in Lyme disease, has only some mild arthralgia in knees, mild cervicalgia, myalgia, occasional tinnitus, questionable paresthesias. Case 3 Slide 4. 107 cardioverted into NSR but reverted to AF within 1 week. Minocycline 200 mg/day begun 1206. Malair1 added 207 for strictly empiric therapy to cover possible pyroplasm co-infection. Repeat echo 507 after 6 months. Minocycline combined for the final 3 months with Malair1, no improvement in F at 20%. AF continued. Minocycline and Malair1 discontinued 607. Patient decides to pursue evaluation for possible trial of valganciclovir with Dr. Montoya at Stanford U Medical Center in view of strongly elevated Ig antibody titers to CMV, EBV, and HHV6. Meanwhile, repeat echocardiogram 2 months after discontinuing Mino/Malair1 shows improvement in F to 30 to 35%, prior to any use of valganciclovir. Not clear, but it is possible antimicrobial treatment might have been responsible for improvement. Intent for patient to undergo either pharmacologic attempts to restore sinus rhythm or catheter ablation of pulmonary vein region of left atrium. Summary. Carditis including cardiomyopathy can be caused by tick-borne infections. Patients with cardiomyopathy deserve thorough evaluation for exposure to tick-borne diseases as possible treatable/reversible etiologies. Other causes for cardiomyopathy must be systematically assessed as well. Close collaboration/cooperation with a cardiologist is mandatory. If there is clinical and/or laboratory evidence of one tick-borne infection, consider the possibility that other tick-borne co-infections might be operative. It may be prudent to cover the most likely bases empirically in dealing with this potentially life-threatening illness, given the insensitivity of current test methods and the fact that Borrelia, Rickettsia/Ehrlichia, pyroplasms, Bartonella species, and mycoplasms all can cause carditis. Minocycline combined with Malair1 would seem a rational and economical regimen that would cover most of the tick-transmissible bacterial/parasitic infections in patients who are felt to have evidence of tick-borne etiology for their carditis. Other regimens may also be acceptable. Systematic comparison of optimal regimens have not been undertaken due to the relative rarity of cardiomyopathy as a complication of tick-borne illness. Summary, Counted. General physicians, cardiologists and other healthcare professionals need to be educated to consider tick-borne illness as one possible etiology of cardiomyopathy. Antimicrobial treatment can sometimes reverse the myocardial dysfunction and abolish life-threatening dysrhythmias and congestive cardiomyopathy and can avert catastrophic outcomes. Early recognition and appropriate treatment, as in other manifestations of Lyme disease, seem most likely to result in optimal outcomes. Late diagnosis can result in irreversible cardiac injury and death. Late application of treatment might result less responsiveness due to scarring of myocardium and/or conduction system. One might want to be circumspect about the use of azalides in patients with carditis/cardiomyopathy because these agents can sometimes prolong the QT interval and may be pro-arrhythmic in that setting. Summary, Counted, food for thought. How many cases of idiopathic cardiomyopathy might result from occult TBDs? What is the excess cost to society for congestive cardiomyopathies and refractory life-threatening dysrhythmias, for example atrial fib, ventricular tachycardias and ventricular fibrillation, requiring pacemakers, implanted automatic defibrillators, hospitalizations and expensive drug therapies and/or cardiac transplantation due to missed diagnoses of tick-borne carditis? What is the extent of avoidable personal suffering for patients and their families consequent to failure to diagnose and treat carditis/cardiomyopathy due to TBDs? Pertinent references: Borne, Marcus L.C., Steer A.C., Dure P.H., Anderson E., Mahoney E.B. Fatal pancarditis in a patient with coexistent Lyme disease and babesiosis. Demonstration of spirochetes in the myocardium. An Intern Med. 1985 September, 103 374-6. PubMed, 4,040,723, PubMed, indexed for Medline. Vlies C., Dervin J. P., Elias J., Kane P. P., Weiler R. Ventricular tachycardia associated with Lyme carditis. M. Hart J. 1991 May, 121 5, 1558-60. No abstract available. PubMed, 2,017,995, PubMed, indexed for Medline. Stanek G., Klein J., Bittner R., Glager D. Borrelia burgdorferi as an etiologic agent in chronic heart failure. Scan J. Infect dis supple. 1991 /77:85-7. PubMed, 1,947,816, PubMed, indexed for Medline. Isolation of Borrelia burgdorferi from the myocardium of a patient with long-standing cardiomyopathy. 10 Engel J. Med. 1990 Jan 25 322-4, 249-52. No abstract available. PubMed, 2,294,450, PubMed, indexed for Medline. Gasser R., Lurcher P., Klein W. Lyme carditis and Borrelia-associated dilated cardiomyopathy. Heart Failure Reviews 1999, 3-241-248. Pertinent references, continued. Babesiosis/pyroplasms. Armstrong P.M., Catabolos P., Caporali D.A., Smith R.P., Spielman A., Telford S.R. 3rd. Diversity of Babesia infecting deer ticks, Ixodustamine. M.J. Tromedhig. 1998 June, 58-6, 739-42. PubMed, 9,660,456, PubMed, indexed for Medline. Persing D.H., Conrad P.A. Babesiosis, new insights from phylogenetic analysis. Infect agents Dis. 1995 December, 44, 182-95. Review. PubMed, 8,665,084, PubMed, indexed for Medline. Persing D.H., Herwalt B.L., Glazer C., Lane R.S., Tomford J.W., Matheson D. Kraus P.J., Philip D.F., Conrad P.A. Infection with a Babesia-like organism in Northern California. N. Engel J. Med. 1995 February 2 332 5, 298-303. PubMed, 8,607,592, PubMed, indexed for Medline. Herwalt B., Persing D.H., Bresegau T.A., Goff W.L., Matheson D.A., Taylor P.W. Eberhardt M.L., Gorenflot A.F. A fatal case of babesiosis in Missouri, identification of another piroplasm that infects humans. An Intern Med. 1996 April 1 124-7, 643-50.